Good afternoon, everyone. Thank you so much for joining our presentation. We will get started in just a few moments. Thank you so much for joining our presentation today on guidance for avoiding fraud, waste, and abuse. This in the Medicaid program, and this presentation is dedicated towards intensive and community providers. Before we launch into the great presentation that we have, just a few housekeeping items. We will be making the slides and the recording available following the presentation. An email will be sent out to all of you with the links to those. We also ask that you keep yourselves muted for the duration, and we're going to go ahead and get started. So my name is Melanie Donnelly, and I'm part of the Office of the State Comptroller's Medicaid Fraud Division. And we are joined today and presenting in partnership with a number of very important key stakeholders, including the Children's System of Care, which is a part of the Department of Children and Families, the Division of Medical Assistance and Health Services, the Medicaid Fraud Control Unit, and the managed care organizations, in addition to the Medicaid Fraud Division. And before we begin, we just want to say thank you for being a part of the New Jersey Family Care Program. The work that you do for the beneficiaries is so critically important, and we are grateful for the work that you do. I do just want to say that this presentation is intended for general educational purposes only, and it does not at all replace your responsibility to seek professional guidance and observe the laws and regulations that are pertinent to your practice as a Medicaid provider. We also just want to say that throughout this presentation, the words Medicaid and New Jersey Family Care might be used interchangeably. NJ Family Care is the name of the Medicaid program in New Jersey, and that includes the Medicaid, CHIP, and Medicaid expansion, with services provided through both the state and 5 Medicaid managed care organizations. Our goals for today are to help all of you better understand the intensive and community providers' responsibilities for Medicaid compliance, the Medicaid regulatory framework and program integrity oversight, documentation requirements for payment, obligations for avoiding fraud, waste, and abuse of Medicaid funds, and potential consequences for non-compliance. So we've got a very full presentation for all of you today. If you have questions throughout the presentation, please input them into the Q&A. And if you're comfortable, please attach your name and email address to them. This will enable us to respond to your questions if we're not able to respond to them in real time during today's presentation or at the end. This will enable us to get in touch with you following the presentation so that we can resolve your questions. We also intend to circulate a list of the questions and corresponding responses to all of you who are on this webinar today. So we also ask that your questions please be de-identified and not include any identifiable provider information. All right, so what is Medicaid? A lot of you probably know Medicaid is a joint federal and state program that provides funding for medical costs and specialized services for people who are eligible to receive them. And participation in the Medicaid program is voluntary. So if you want to participate, you must know and accept and abide by the rules and the regulations. And continuing to be a part of the Medicaid program requires compliance with regulatory requirements. This slide just gives an overview of the various New Jersey state agencies that are involved in overseeing the Medicaid program, as well as their parent agency. So on today's call, we've got representatives from the Medicaid Fraud Control Unit, which sits within the Department of Law and Public Safety under the Office of the Insurance Fraud Prosecutor. We also have the Division of Medical Assistance and Health Services, which is part of the Department of Human Services. My agency, which is the Medicaid Fraud Division, which is part of the Office of the State Comptroller. And then last but certainly not least, the Children's System of Care, which is part of the Department of Children and Families. And with that, I'm going to turn it over to representatives from the Department of Children and Families so that they can get things started.
Thanks so much, Melanie. Can you hear me okay?
You sound great.
Okay. I appreciate that introduction. I'm Wendy Davis. I work as the Assistant Director in the Office of Community Services, and I'm delighted to be here with Kelly Figueroa, our Intensive in Community Program Lead for the Intensive in Community and VA service line within the Department of Children and Families, which we're representing today. Our department is the state's first cabinet level agency devoted exclusively to serving and supporting at-risk children and families. I should say I wanted to just start with a little orientation of our department and our division. Our vision is to assist and empower all New Jersey residents to become safe, healthy, and connected, as most of you know. And we do have division core approaches or department core approaches outlined, including race equity, healing-centered, protective factors framework, family voice, and collaborative safety. And we work to embed those in all that we do. I mention them specifically because that's inclusive of the work that we do and that you all do within the community. Next slide, please. Thank you. CSOC is the New Jersey's public behavioral health system for youth under 21. We are one of the 4 main divisions in the Department of Children and Families, with child protection, permanency, family and community partnerships, and the Division on Women. We have 5 offices in our division, and we represent the Office of Community Services, which houses oversight for our system partners and community-based providers, including intensive and community. CSOC was established in the early 2000s to serve youth with behavioral health needs, and we expanded our scope in 2013 to include services for youth with IDD challenges and substance use challenges. We are a coordinated network of services and supports that relies on the youth and families really being at the center of their own care and aims to support youth and families within the community and with an approach that's mindful of cultural context, social determinants of health, and how these things impact families. Next slide, please. CSOC operates in alignment with the system of care values and wraparound principles listed here, which have informed the development and maturation of the system of care. They continue to drive our practice and decision-making at both the system and service levels today. Next slide, please. Thank you. In 2021, we served over 58,000 youth ages 3 to 21. That's 1 out of every 33 children in New Jersey. It's important to note that services from CSOC are available to youth regardless of their ability to pay. 35% of youth who access our services are uninsured, underinsured, or have private insurance that doesn't cover the costs of CSOC services, and 65% have Medicaid coverage. In the last 2 years, the pandemic has impacted our service utilization trends. We've seen dramatic declines during shutdown and surges, increases month over month as we've moved through the pandemic. And we presently see historically high utilization across our service lines. Next slide, please. Children's System of Care functions as a managed behavioral health system for youth with moderate to high acuity needs. CSOC contracts with a wide array of partners and providers to deliver supports and services for youth and families. These supports and services are reimbursed with federal and state funds. Most of you are familiar with our core components listed here. Our CSA, Perform Care, is a non-risk administrative service organization that provides member services, medical necessity determinations, prior authorization, quality management functions, as well as development and maintenance of our cyber record, which is used across CSOC. They do not, however, manage payment. Claims are paid through the state's Medicaid fiscal agent. As you know, each of our 15 service areas has a CMO, mobile response, and FSO, with whom you should be familiar and coordinating with for care. CSOC has developed a broad array of in-home and out-of-home treatment services for which we manage the network for all service lines. We don't manage lower intensity outpatient, and we don't manage the CCIS high acuity inpatient beds, just for clarity. And we do also fund and manage our workforce training certification and TA delivered by Rutgers. We'll talk a little bit more about how that applies to you all later. Okay, next slide, please. New Jersey had a vision nearly 2 decades ago to develop a comprehensive, coordinated, community-based system of care to support youth and families early when their needs arise and regardless of their system involvement. IIC was established as a part of this in 2005 through state plan amendment under the rehabilitative option, and it's governed by state Medicaid regulations. Medicaid holds authority, and CSOC is responsible in coordination with Medicaid for provider enrollment and network coordination, as well as oversight of service delivery. We work closely with Medicaid, our single state authority. IIC does have a Medicaid fee-for-service reimbursement model. The Medicaid regulations outline the program descriptions for IIC and VA, which you should all be pretty familiar with. IIC are short-term therapeutic services provided to youth experiencing emotional and behavioral challenges in their families. Services are provided in person within the community or home as driven by the family. Youth must be engaged with care management or mobile to access these services, and they can be provided as part of transition home from out of home. Behavioral assistance services deliver specific outcome-oriented interventions that address specific target behaviors. These services help family and youth to develop and practice healthy and positive coping strategies and techniques. BAs offer targeted skill development through positive behavioral supports and other approaches, including social and emotional learning. In order to receive BA, an intensive and community therapist must also be working with the youth and family. CSOC maintains clinical criteria for both services that outlines program description, intent of services, admission, continued stay, and transition criteria. And as mentioned, Perform Care provides prior auth and utilization management, or UM. This is important. Intensive and community services are designed as face-to-face interventions. During the pandemic, IIC services were allowed to be delivered via telehealth within existing statutes and guidance, including DCF's practice guidance, which outlines a standard of care for decision-making support around the use of telehealth. This includes the family driving the request. This includes that it is identified in the plan of care as appropriate and that it meets outlined standards of care. We have heard from many of our families and youth who identify the large benefit and importance of in-person service delivery, both developmentally and relationally within their family. Next slide, please. At this point, I'm going to introduce you, if not in face, but in voice, to Kelly Figueroa, our program lead for IIC, who's going to talk a little bit more about the details of roles and responsibilities and practice reminders. Kel?
Thank you, Wendy. Good afternoon, everyone. So the roles and responsibilities outlined here are integral to IIC service delivery within CSOC, and how they are implemented is key to agency youth and family success. Approach will integrate system of care values and principles and focus on engagement with youth and families. Ongoing assessment, planning, and progress monitoring, as well as documentation of all efforts, are required to cover authorized service delivery dates. Service orientation, contextual, and psychoeducational information are key elements in service delivery for youth and families. Skill building is a key goal, and relevant strategies supporting this should be included in the plan of care. Transition planning begins at the start of service delivery and includes preparing youth and families for transition to community-based supports as needed. CMO and mobile response agencies serve as your referral sources and ongoing collaboration for individuals through the CFT attendance. Communication of progress or barriers to treatment is integral to youth and family success. Routine system level collaboration and communication helps ensuring quality service provisions and clear service delivery and collaboration expectations. IIC agencies are encouraged to participate in the local kayaks for relationship building, community collaboration, and resource knowledge. IIC agencies are obligated to follow all relevant rules applicable to their service delivery, including Medicaid, IIC, and BA regulations and other regulations, in addition to applicable licensure board statutes and regulations, including but not limited to ethical standards and dual relationships and conflict of interest standards. The next slide. This next slide lists several board sites for your reference on licensing board authority. Next slide. Required credentials for IIC agencies for IIC and BA staff are outlined in the Medicaid regulations 1077, 4.7, and 5.7. More information about Medicaid regulations will be referenced later in this presentation, and a categorical overview will be provided in an addendum. We will highlight a few practice standards implemented by CSOC that are in addition to these regulations relative to credentials. 2 levels of IIC credentials are allowable: clinical and professional. Clinical must be delivered by an independently licensed behavioral health care practitioner. Professional level IIC may be delivered by a master's level direct care provider who must be supervised by an independently licensed practitioner operating within the scope of their profession and pertinent statutes and regulations. They must have an approved plan of supervision typically submitted to and approved by their board. IICs must seek guidance from their board, who is the authority on the scope of practice. Most typically, master's prepared individuals will have a journey person license, for example, an LSW, LAC, or LAMFT. The plan of care and specific models and strategies utilized is determined by the IIC in the context of the child family team and must be documented and outlined in the individualized treatment plan. Caregivers must be involved in the treatment per regulation. Caregiver family strategy should support the parent to implement strategies to support the youth and meeting their needs, which sit in the family context. The youth does not have to be present, and best practices is that treatment is coordinated within the family system. A service targeted specifically for the parent outside of the strategies and intent to support parent in specific goals for youth would not fall under IIC. All IIC staff are required to attend IIC BA orientation offered by Rutgers UBHC. IIC supervising BAs have an additional required training component. Next slide, please. Okay, BAs must implement services as outlined in a plan developed by a licensed behavioral healthcare practitioner prior to the BA meeting with the family and implementation of BA services. BA services are comprised of specific outcome-oriented interventions that are components of an approved written detailed plan of care, the BISP, which is prepared by the IIC, who is also working with the family. BA is not mentoring. The BA should discuss the plan frequently with the IIC to ensure that the plan is being implemented according to the IIC's recommendations and is effective. BA service was defined to include the transfer of skills to the youth and is learning to the parent caregiver and transition to community supports. While the regulations require BAs to have a minimum of a high school diploma or equivalent, be 21 years old and have a minimum of 1 year relevant experience in a comparable environment and shall be supervised by appropriate clinical staff. In accordance with this subchapter, these are the minimum standards. CSOC encourages IIC agencies to consider candidates' education beyond a high school diploma and relevant work experience, as these ensure the candidate's readiness to become certified to provide BA services. BAs are required to attend the IIC BA orientation through Rutgers. BAs are required to obtain BA certification within 6 months of their hire date. This requires training, online review, and core competency attestation by supervisors and to recertify annually. Certification website is referenced above. 2 additional services were supported under the New Jersey Medicaid Comprehensive Waiver to deliver SEL services by BA staff under a licensed clinician plan of care under the umbrella of SEL, transitioning youth, life skill building, and youth support and training. An additional certification is required by both the BA and the IIC to deliver these services. It should be noted separate and distinct service codes exist for this service and should be requested by CMO Mobile when BAs and IICs are requested to deliver these services. Next slide, please. IIC service allows for delivery of the BPS, which has required elements in these categories, which we will review in the next slides. The purpose of the BPS is to provide a comprehensive clinical assessment geared to identify needs pertaining to behavioral health, developmental challenges, and/or substance use challenges, and treatment recommendations to address these needs through both local community resources, family resources, and services available through New Jersey CSOC service continuum. The BPS serves as an intervention in and of itself. Please see the link for BPS reminders and best practices. Next slide, please. Independent clinical licensure is required to complete the BPS. An independent licensed practitioner cannot sign off as a supervisor for the journey person licensee. The service code utilized must match the credential of the independently licensed IIC practitioner. This person must also document the information within cyber. The BPS assessment documentation includes a narrative template as well as the Strength and Needs Assessment Tool. Annual recertification of the Strength and Needs Assessment Tool is required. Both must be entered within cyber. Timely completion and documentation is important as it impacts timely access to further service delivery for families. Next slide, please. BPS assessors must schedule an appointment with the family and youth within 3 days of initial authorization. If a provider does not have capacity to provide the assessment, they must notify Perform Care within 3 days of the authorization start date. Providers are required to manage their capacity to provide BPS assessments routinely within cyber through the randomizer indicator. This indicator is strictly for indicating capacity for BPS referrals. When an agency does not have the staff capacity to conduct a BPS, they should deactivate the randomizer checkbox within the cyber provider details page. Now, the agency has access to activate and deactivate the randomizer at any time in cyber. Completed BPS assessments, but must be submitted within 10 business days of the authorization start date. If returned due to need for additional information, the BPS should be revised and resubmitted as soon as possible and within no longer than 5 business days. Assessments should be completed and approved within cyber prior to submitting a claim for the service. Providers who are approved to provide a BPS in detention centers must submit the assessment within 5 business days for the initial. Next slide, please. CSOC requires all individual level documentation to be maintained in our electronic system cyber. The elements include treatment plans that cover the service delivery timeframe every 90 days minimally and coordinated with the CFT and CMO. Progress notes with each service delivery date, documented attempts at connecting with families and youth, timely in relation to service delivery, fact-based and inclusive of goals addressed, strategies and progress, as well as diagnosis. BPS is to be documented in the cyber format as well. All the documentation must be entered by staff delivering the service. Regulations additionally outline information needed to be maintained on file by the provider for each staff, including successful background check record and valid driver's license. More information regarding the documentation will be discussed shortly by Medicaid regarding the requirements in the Medicaid regulations. Next slide. And see something. Okay, so cyber as a shared single electronic record offers many benefits and functionality that supports coordination of care and provider management. We have discussed functionality that allows for individual service delivery documentation. In addition, IIC cyber users have access to a welcome page and My Active Youth link that supports management and tracking of documentation requirements, prior authorization generation and expiration, NJFC and 3560 eligibility and non-Medicaid claim status related to youth they are serving. Role-based security allows for a hierarchy structure designed to allow supervisors and managers the ability to track the work of their staff. Specifically, it allows them to establish a quality documentation review and oversight process. Several reports are available to providers to manage their security access, authorization, and progress note documentation. Last, providers have access to a provider details page that will display contact information is entered into the Medicaid system. The provider should review and update their contact information with the Medicaid provider enrollment or NJMMIS as needed routinely. As well, providers can enter information regarding specialties and geographic areas served, which is available to system partners and can support proper referrals from partners and ensure any changes are documented. The randomizer is also housed on this page. And I'm going to pass it back over to Wendy. Thank you.
Thanks so much, Kelly. I wanted to just mention that IIC service delivery requires a number of administrative functions, many of which we have discussed. In addition to those, providers are reminded to verify authorization and eligibility prior to service delivery. Regulations require agencies to implement a robust system of quality assurance and oversight that includes family satisfaction and youth satisfaction and requires compliance on an ongoing basis and adjusts service delivery to maintain outlined standards. Although IIC providers aren't required to submit unusual incident reports directly, they must coordinate reporting of unusual incidents of which they are aware with the CMO and mobile response providers and respond to CSOC inquiries related to response to unusual incident reports. Next slide, please. As mentioned, IIC has a fee-for-service reimbursement model, and claiming is primarily completed through the Medicaid fiscal agent. Billing training is available for all IIC VA providers through Medicaid. Youth not Medicaid eligible may receive services through state-only eligibility process and funds. Claims, including those for youth with 3560 eligibility, are processed through the Medicaid fiscal agent. Claims for BPS assessments for non-Medicaid eligible youth and those who are not yet involved with mobile response or CMO are processed through Perform Care. These services are still subject to the regulatory requirements and standards as discussed. The Perform Care training on billing through cyber is located at the link above. The service delivery encounter documentation form is required to be completed for each date of service and must be signed by the caregiver. This documentation is required to be maintained on file to support billing activity and for claims processed through Perform Care, which again are a very small portion. This form must be submitted with the claims. The link to the form is located here. As a reminder, the billing codes must reflect the proper code for the credentialed provider delivering the service. There is a list of billing codes for IIC and VA services within this slide deck or the appendix. Group codes are not typically authorized at this time. Last, a reminder that the application to become a provider is located on the DCF CSOC website, as are the change of staff forms. All applications are initially processed by CSOC to ensure that required documentation is complete prior to forwarding to Medicaid for their review and approval. Additionally, providers are required to submit change of staff forms anytime a staff leaves or you want them to join your agency. The form must be approved by CSOC prior to staff being hired. We really do appreciate your time today. And now we'll hear from Melissa Martin.
Thank you, Wendy. Hi, everyone. My name is Melissa Martin, and I am from AmeriGroup. I am going to be talking about the documentation, records, retention, and billing practices. It is extremely important to accurately document services. Documentation should occur at the same time as the services rendered. The billing must occur daily for each day you provide services. It is the provider's responsibility to know and comply with documentation requirements. Next slide. The Medicaid documentation requirements are that the provider shall agree to the following: to keep such records necessary to fully disclose the extent of services provided, and to retain individual records for the greatest length of time that applies from the date the service was rendered, to timely furnish information about such services as requested by regulatory agencies, including the Medicaid Fraud Division. If records do not document the type and extent of services billed, payment adjustments are necessary, including requiring repayment to Medicaid or claim payment denial. All records and documentation used to support billing must be individualized, reflect actual services delivered, and include the individual's name, the date of the service, the time and the duration, the specific services rendered, such as intensive in community, individual biopsychosocial, behavior assistance program, individual inclusive of SEL. Description of the encounter and notation of unusual occurrences, the signature of the person authoring the note, the signature of a supervisor if required, service delivery encounter documentation forms signed by caregiver. Notes must be aligned with the service or treatment plan's outcomes and strategies. Answer the who, what, where, when, why of service provisions. Be completed by either the individual providing the services or an individual responsible for the oversight of the direct service provision. If the note is completed by a staff member not providing the direct service, they should reflect progress towards or decline from the identified outcomes. Comply with IIC requirements as detailed by New Jersey's Administrative Code 1077-4N5. Next slide. Notes also must provide providers using the electronic health record or other electronic systems must ensure that all information required in mandatory section is included and individualized for the recipient, and that all underlying documentation can be produced to support services rendered during an audit or an investigation. The notes cannot be completed by a staff person not connected to the service provision, be duplicative or generic in nature. The records must accurately reflect the services that were rendered, should occur at the same time as the services rendered. Medicaid will not pay for undocumented or improperly documented services. Don't shortchange yourselves. If it's not documented or not documented correctly, it just wasn't done. Now, according to the records retention timelines that are approved by Medicaid, New Jersey Family Care enrolled intensive in-community mental health rehabilitation providers shall retain in a secure location and in compliance with all applicable federal and state laws and regulations, confidential information related to the individuals providing or supervising the provision of services, and shall produce the information for the Department of Human Services, Children and Families, or any authorized agent of either department in an orderly fashion on demand. The timelines vary depending upon the source. You have the New Jersey Code, Section 1037, 6.77. Records of adults must be retained for 5 years after the last date of service. For children, it must be retained 5 years after they reach their 18th birthday. According to Article 7.28.A of the MCO contract, it's 10 years. Follow the regulation with the greatest length of time that pertains to you. With billing and the coding, the use of specific codes by the provider that accurately report the service rendered are required to receive payment for those services. The codes that are used on the claim form are on the following slide. You can see here there's a list of them that you can refer to at your leisure. Next slide. The responsibility in the billing practices, it is the provider's responsibility to ensure that claims submitted for payment reflect the actual service that was provided, who performed the service, the location of the service, the billing entity, and the time duration for the claims that are time-based. It is incumbent upon providers to be knowledgeable regarding the codes that are used to reflect the services rendered. You need to implement a robust system of quality assurance and oversight that reviews compliance on an ongoing basis and adjusts service delivery to meet outlined standards. Supplemental documentation to a note can be added if necessary, as long as the date of the addition is included, as well as the initials of the person supplementing the record. I'm going to pass it now over to Steve or Melanie to talk about the guiding regulations.
Okay, thank you. Guess the next slide. So the guiding regulations in New Jersey Medicaid for IIC service and BA services is 1077, subchapters 4 and 5. As providers, it's your responsibility to know these regulations and observe them. The regulations tell you who can provide the services, who can receive the services. Not everybody with a Medicaid ID number gets the same exact service package, so please make sure that you check that. If you verify the ID number, it tells you, based on your provider number, what services that person is eligible to get or not get. The limits on the services, the allowable versus non-allowable services, and documentation requirements. Frequency guidelines and billing codes are also listed in the regulations. And if you have any questions, you can always call the provider hotline, 800-776-6334. If in doubt, it's better to verify something rather than going months and risking having have those funds recovered. Next slide. Newsletters are used to introduce new programs or services, pending regulatory updates or general program guidance. We just went through this with IIC when we put out a newsletter prior to the regulations going out for promulgation. Newsletters are found on Gainwell's website. It's www.njmmis.com. There's two sections you can check a newsletter. One says new or recent. The other one is newsletters and alerts. If you're not sure of the time frame, make sure you use newsletters and alerts. It'll give you the full package. The recent is only, I think, the last 6 months to a year. The newsletters are searchable by provider type and subject. The subject is a little iffy. You could put in there something like fingerprint checks, and if it hits, it will bring that newsletter up. But if it doesn't hit, don't assume that there isn't a newsletter there. It's always better to search by your provider type and a time frame if you have a good idea, and then just look at all the newsletters that come out. Sometimes the names that are put on those newsletters can be a little bit misleading, or they could deal with more than one subject. Next slide. Slide. Newsletter volume 32, number 24, was released in September to notify providers about clarifications related to background checks and driver's license verification requirements. All providers that previously failed to satisfy the background check requirement, as well as all new providers coming in, will have to complete that background check through the Employment Controls and Compliance Unit, the ECU, at the Department of Human Services approved vendor. The fingerprints are free to providers. That cost is covered by DHS. Copies of a successful background check, valid driver's license, and proof of highest educational level attained must be submitted to CSOC to grant employees access to cyber. So if you haven't had your fingerprint completed, shown proof that the driver's license is valid, and then submitted the highest education level you have, you will not receive access, you won't be able to document, and then you should not be billing for that service. Next slide. Providers have to provide proof of their driver's license annually for all active employees whose job responsibility requires them to transport family members. This includes attestations that the license were in the staff member's possession and that the license was physically reviewed and noted to have a future expiration date. Staff with a driver's license expiration date that's within 2 months, that should be rechecked just to make sure that the staff did follow through and get that license renewal. Required verification documentation form is available on the DCF website. It's just a simple form. You fill out all the staff, and then you can submit electronically to CSOC's Office of Community Services, Provider Enrollment Unit every January, and you'll meet these requirements. Next slide. The provider is responsible to verify and maintain a copy of documentation that the staff is qualified and trained. So in other words, you have to verify their credentials, certifications, licenses, establish training schedules, whatever is in your policy and procedure manual. That is your responsibility. It's not just a fingerprint background check and a driver's license. Ensure that all new or potential staff have no disqualifying criminal issues before permitting the provision of services. This means that you have to get a clear letter back through ECU before that person starts to provide actual services. This can be done electronically through the FARA. Once the staff complete the fingerprint process, they retrieve a copy of their cleared letter from ECU's online fingerprint approval, retrieval, and application website. And then that is your proof that the Department of Human Services went through, verified that there was nothing in a criminal background check that would prevent that person from being hired. Instructions are found at the website that's listed. Next slide. Public health emergency. Public health emergency has created a lot of different waivers and requirements, and this one was probably more for independent clinics than your provider type. But like the Department of Healthcare provider required 6 feet of spacing, required everyone to wear masks. It required mandatory vaccines for staff. Those are slowly starting to be peeled back, and I believe in April, they anticipate that the public health emergency is going to be ended, in which case everything will revert back to the common rules that we have now. So telehealth is currently allowed in response to the PHE for all providers that Medicaid pays, and you would follow whatever requirements there are that you would do as if you were providing that service face to face. The temporary telehealth guidelines were in newsletter volume 30, number 9. But once, as I said, as the PHE winds down and these waivers go away, the rule that we will be following will be the telehealth law, which was updated in 2021, and it provides the guidance after the telehealth waivers are lifted. There are federal rules and requirements that are changing as we speak. They are much like the New Jersey divisions are making regulations, Department of Health and Consumer Affairs. Obviously, if they pass a regulation related to something that's licensed, then that will follow that guidance as well. But the federal government is making requirements for telehealth as well. So I don't know that any of those may or may not apply to children's services, but if they do, you'd be under Medicaid, you're required to follow the federal rules as well. I think that's my last slide. I don't know who's next, sorry.
Hi, this is Tracy Livingston from the Medicaid Fraud Division, and I'm going to talk about the compliance program and the things that we want to make sure that you guys have in place. So over the next couple of slides, I'm going to talk about a few things. The first thing is this, we have here the 6 steps towards compliance. There's a couple of things here we have on this slide. A couple of things are providing clinically appropriate services as identified in your treatment plan, accurately documenting the services of who, what, and when, and how the services were provided, instituting a responsible billing practice, properly supervising all employees for provisions of services, establishing a system to identify and correct errors and omissions concerning credentialing, documentation, and billing, and adhering to waiver regulatory standards where applicable. One of the things I want you guys to really understand about this slide is that your program, your compliance program is unique to your business model. So you want to make sure you have everything that we're talking about in this slide in your model, but your compliance program is your compliance program. So if we ever have to look at anything, one of the things we look at your compliance program, and then we make sure that you're following the program that you wrote. So I just want to make sure that you guys understand that it's unique to each of your businesses. Next slide, please. Thank you. So there's also a couple of consequences to, to not having a really good compliance program and also following that program. Non-compliance with Medicare rules, standards, and regulations regarding services may constitute acts of fraud, waste, or abuse of Medicaid funds. And this is another thing that we want to point out. We realize that many of our providers do great work, but we also want you to remember that part of doing that great work is protecting your patients from fraud, waste, and abuse, and remembering that Medicaid funds are taxpayers' funds. So again, like you putting together a good compliance plan, it protects you, it protects your patients, and also protects the program, which at the end of the day is all of our goal. About the Medicaid Fraud Division. The Medicaid Fraud Division was created by the Medicaid Program Integrity Protection Act. And this was established by the Office of Medicaid Inspector General to detect, prevent, and investigate Medicaid fraud and abuse, recover improperly expended Medicaid funds, enforce Medicaid rules and regulations, audit cost reports, claims, and review the quality of care given to Medicaid recipients. These functions, powers, and duties were later transferred to the Office of the State Controller and are carried out by the Medicaid Fraud Division. Next slide, please. More about the Medicaid Fraud Division. The Medicaid Fraud Division also performs program integrity functions, include conducting audits and investigations of potential fraud, waste, and abuse, coordinate program integrity oversight efforts among all state agencies, and provide and administer Medicaid services and programs. One thing we really want you guys to understand about the Medicaid Fraud Division, our main goal is to protect the Medicaid program, protect the recipients, protect actually the providers as well, and they're also protect taxpayers' dollars. So when we come in, one of the things we want to make sure again, that the policy and procedures that you guys put in place, that you're following those policy and procedures, and those policy and procedures that you're following is based on current law, rules, and regulations. So it's one of the things that we want to make sure that everyone is doing. Okay, about the Medicaid, last slide. About the Medicaid Fraud Division. The Medicaid Fraud Division also we enforce rules and regulation, audit cost reports, and claims. Now, one thing we want to really make sure, MFD has a very important duty where we are tasked with safeguarding how taxpayer money is spent. And in the Medicaid program, through various means that we discuss, such as audits and investigations. Our office is also tasked with reviewing and possibly removing providers who have serious compliance issues, because having these problematic providers in the Medicaid program can possibly overshadow the positive work of many of the providers in the program who are doing great work for our Medicaid recipients. So again, we just want you guys to understand that we're here to make sure that you guys are doing everything properly for the compliance program, and we're here to make sure that that's done properly. I'm now going to turn this over to Brittany Scheichel. Thank you.
Thanks, Tracy, and good afternoon, everyone. Once again, my name is Brittany Scheichel, and I am with United Healthcare, and I will be discussing what is fraud, waste, and abuse. Now, fraud is defined as an intentional deception or misrepresentation made by any person with the knowledge that the deception could result in some unauthorized benefit to the person or another person, including any act that constitutes fraud under applicable federal or state law. Next slide. Now, some of the consequences that can occur, civil consequences that can occur due to Medicaid fraud, waste, and abuse are civil judgments and liens, exclusion from the Medicaid or Medicare program, suspension or loss of professional licenses, referral for criminal prosecution, restitution or recovery of overpayments that were made, and then additional penalties in addition to repaying those Medicaid overpayments. Next slide, please. Now, waste is generally understood to encompass overutilization or the misuse of resources. It is not usually considered a criminal act, but it is considered a legal violation for civil purposes and can result in a recovery of an overpayment, debarment from the Medicaid program, or any additional penalties. Abuse is defined as provider practices that are inconsistent with proper, sound fiscal, business, or professional or service delivery practices that can result in unnecessary costs to or improper payment by Medicaid, or reimbursement for services that are not necessary, that were not approved, that are not documented, and that are outside of what was specifically authorized. Waste and abuse professional due diligence. Business practices that result in waste and abuse can rise to the level of fraud. And some of the examples are providing services without proper authorization, of course, unless it's an emergent situation, using unlicensed, unqualified, or untrained staff, inaccurate or incomplete documentation of services, billing for undocumented or unsubstantiated services, and insufficient internal checks and balances. Now I'll pass this over to Sanjeev Basi with the MFD to discuss some audit finding examples.
Thank you, Brittany. Good afternoon, everyone. And this is Sanjeev Basi from Medicaid Fraud Division. Today, I will be talking about the audit findings, which we have noted from our past and current ongoing audits of the providers who provide services under the Intensive in Community and Behavioral Assistance Service Program. Next slide, please. One of the findings we have noted is for the criminal background checks. According to the state regulation 1077 4.9, all employees rendering behavioral assistance services to the beneficiaries shall be required to successfully complete criminal background checks. Further, according to the state regulation 1077 4.14, the provider must maintain verified written documentation of the successful completion of a criminal background check. Basically, what it means is that providers employing BAs must ensure that their BAs successfully complete and clear criminal background checks and must maintain a record showing the successful completion and clearance of these checks. This ensures that BAs who are providing one-on-one care to the Medicaid beneficiaries do not have a criminal history. This increases the assurance that the BAs will not compromise the safety and security of the beneficiaries. Based on the past and current ongoing audits, we have noted that some of the providers did not maintain any evidence of the successful completion of the criminal background checks. This is not acceptable as the regulation clearly requires providers to maintain the criminal background checks. Further, we have also noted that some of the providers obtained criminal background checks subsequent to the BA providing services. For example, in one instance from one of our recent audits, one of the providers billed and was paid for a claim for a service dated June 27, 2017, but did not obtain a successfully completed background check until February 4th of 2021, nearly 4 years after the date of service. Again, this is not acceptable because the providers are supposed to ensure that BAs who are providing one-on-one care to the Medicaid beneficiaries do not have a criminal history. If providers are verifying this information after rendering services, then they're putting the beneficiaries at risk. Next slide, please. Another finding we have noted is for the behavioral assistant training certifications. According to the state regulation 1077 4.14, the provider must maintain verified written documentation of the direct care staff person's successful completion of behavioral assistant training certification as required by the Department of Children and Families. Basically, what it means is that providers employing BAs must ensure that the BAs have gone through extensive training and obtained a behavioral assistant training certification within 6 months of the hire date, and they are recertified annually thereafter to continue providing BA services. To be certified, BAs must attend live trainings, meet 13 core competencies, and successfully pass an online review. For annual recertification, BAs must attend live training and meet core competencies. These certification requirements increase the assurance that beneficiaries receive the proper quality of care. Based on the past and current ongoing audits, we have noted that some of the providers did not maintain any evidence of these certifications. This is not acceptable as the regulation clearly requires providers to maintain these certifications. Another important thing to note is that attending training sessions is not adequate to satisfy this requirement. A test must be passed and training certificate must be maintained by the provider. Next slide, please. Another finding we have noted is related to the education of the behavioral assistants. According to the state regulation 1077 4.9, all direct care staff shall at a minimum have a high school diploma or equivalent. Further, according to the state regulation 1077 4.14, the provider must maintain a copy of the direct care staff person's high school diploma or equivalent. Basically, these requirements provide a level of assurance that BAs possess the academic skills by completing the high school education or an equivalent, and they're socially responsible enough to work in a one-on-one setting with the beneficiary population. Based on the past and current ongoing audits, we have noted that some of the providers did not maintain any evidence that satisfied the minimum educational requirement. This is not acceptable as the regulation clearly requires providers to maintain proof that the BAs satisfy this educational requirement. Another finding we have noted is for the failure to maintain current and valid driver's licenses for behavioral assistants. According to the state regulation 1077 4.9, all employees shall have a valid driver's license if his or her job functions include the operation of a vehicle used in the transportation of the children, youth, or young adults. Further, according to the state regulation 1077 4.14, providers must maintain a copy of his or her current valid driver's license. Basically, what it means is that oftentimes BAs render behavioral assistance services to the beneficiaries outside of their place of residence, such as in playgrounds and other in-community settings. For such services, BAs may drive beneficiaries to the service location. As such, state regulations require all BAs to have a current and valid driver's license and providers to maintain a copy of each BA's valid driver's license. Based on the past and current ongoing audits, we have noted that some of the providers did not maintain any evidence that satisfied the driver's license requirement. Also, some providers maintained only the driver's license obtained at the time of hire and did not verify and maintain subsequent driver's licenses after the original had expired. This is not acceptable as the regulation clearly requires providers to maintain proof of current valid driver's license. Next slide, please. Another finding we have noted is related to the hiring of BAs who are not at least 21 years of age or older. According to the state regulation 1077 4.9, all direct care staff shall at a minimum be 21 years old. Further, according to the state regulation 1077 4.14, providers should maintain a copy of the direct care staff person's proof of age at the date of hire. Basically, what it means is that providers employing BAs must verify that the BAs meet the minimum age criteria. Based on the past and current ongoing audits, we have noted that some of the providers did not maintain any evidence that satisfied the minimum age criteria. Also, some providers allowed services to be provided by a BA who was under the age of 21 when the services were rendered. This is not acceptable as the regulation clearly requires BAs to be at least 21 when rendering services, and providers should maintain proof of the age. Next slide, please. Another finding we have noted is related to hiring unlicensed professionals to render services. Within the intensive in-community program, there are certain services which are rendered by licensed professionals. Pursuant to the state regulation 1077 5.7, clinical services shall be delivered by a licensed clinical professional. Further, according to the state regulation 1077 5.14, the verifiable written documentation of the healthcare practitioner's credentials and license must be maintained. Basically, what it means is that before letting the servicing providers to render services, the providers must ensure that the servicing providers who need a professional license are in fact licensed. This requirement ensures that intensive in-community servicing providers who are providing clinical level one-on-one care for Medicaid beneficiaries have the proper level of education, training, and have gone through various state and federal criminal history background checks prior to providing such services. Based on the past and current ongoing audits, we have noted that some of the providers hired unlicensed professionals to render services. Another issue we have noted is that some of the providers obtained professional licenses subsequent to the servicing provider providing services. For example, in one instance from one of our recent audits, service was rendered on January 1, 2020, but the license was obtained on June 30, 2020, 6 months after the service date. This is not acceptable because providers are supposed to ensure that professionals who are providing one-on-one care to Medicaid beneficiaries are properly licensed. If providers are verifying this information after rendering services, then they're putting the beneficiaries at risk. Another finding we have noted is related to not maintaining proper service delivery encounter documentation forms. State Medicaid regulations such as 1049 9.8, 1077 4.12, and 1077 5.12 require providers to maintain true, accurate, and complete records for each encounter, documenting the name and address of the beneficiary, the exact date, location, and time of service, the type of service, and the length of face-to-face contact time. All this information is contained on the service delivery encounter documentation form. This 2-page form must be signed and dated by the servicing provider who rendered the service and by the beneficiary or the parent legal guardian for every service encounter between a provider and the beneficiary. Based on the past and current ongoing audits, we have noted that some of the providers either did not maintain the SDD forms at all or maintained SDD forms which were incomplete, such as forms were not signed by the servicing providers or by parent or guardian, encounter dates and times were missing, or other required information on page 1 or page 2 was not fully completed. This is not acceptable as the regulation requires providers to maintain true, accurate, and complete information. Next slide, please. Continuing with the STD forms, another issue we have noted is that some providers billed for services which were never rendered. State Medicaid regulations such as 1077 4.12 and 1077 5.12 require providers to maintain documentary support of all intensive in-community and behavioral assistance services, including the exact date, location, and time of service, which must be true, accurate, and complete for each encounter. Now, for example, and this is an example from one of our audits, one service delivery encounter documentation form documented that services took place on January 25, 2019 from 6 p.m. to 8:30 p.m. Second service delivery encounter form documented services to a different Medicaid beneficiary from 6 p.m. to 8:30 p.m. same time by the same servicing provider on the same date, meaning one of the service was not rendered but was billed to Medicaid, as a servicing provider cannot be at two places at the same time. This is not acceptable. Continuing with the STD forms, another issue we have noted is that some providers would improperly bill for travel time to and from the location of the beneficiary as part of its billing for face-to-face services. State Medicaid regulations such as 1077 4.12 and 1077 5.12 require providers to maintain documentary support for the length of face-to-face contact time, excluding travel time to or from the location of the beneficiary, and the records must be true, accurate, and complete for each encounter, which contains this information. Now, for example, and this is an example from one of our audits, one service delivery encounter documentation form documented that one servicing provider rendered services to a beneficiary on July 19th from 8:30 a.m. to 10:30 a.m. A second SDD form for that same date, July 19th, documented that the same servicing provider rendered services to a different beneficiary from 10:30 a.m. to 12:30 p.m. The two service locations were 62 miles apart. So first one was 8:30 to 10:30, the second was 10:30 to 12:30, and the two service encounters were 62 miles apart, requiring approximately 1 hour and 5 minutes of travel time. In that instance, the provider improperly billed travel time as part of its face-to-face services, as it did not account for any time needed for travel. This is not acceptable. Next slide, please. Another finding we have noted is related to not documenting the progress notes. Pursuant to the state regulation 1077 4.12 and 1077 5.12, the provider shall maintain progress notes towards defined goals as stipulated in the plan of care. Basically, what it means is that for both intensive in-community and behavioral assistance services, the servicing provider must document services provided through progress notes. These notes should provide relevant information regarding the treatment provided, the beneficiary's response to the treatment, significant events that may affect the beneficiary's condition or treatment, and other important information related to the beneficiary's plan of care. Based on the past and current ongoing audits, we have noted that some of the providers either did not maintain the progress notes at all or maintained progress notes that lacked necessary information. This is not acceptable, as the regulation clearly requires providers to maintain progress notes. Well, that concludes the audit findings section, and now I will pass on to Melanie.
Hi, everyone. This is Melanie Donnelly from the Medicaid Fraud Division, and I'm just going to jump a little bit back to what Tracy had been speaking about regarding the Medicaid Fraud Division, and I'm going to dive into some of the actions that we have the ability to take, exclusions, and self-disclosures. So, in instances where the Medicaid Fraud Division has conducted an audit or an investigation and has identified an overpayment, we can initiate a number of actions in order to recoup those improperly paid funds. And those actions include sending a notice of estimated overpayment or notice of intent, and if necessary, a notice of claim. We may file a certificate of debt on any real estate property owned by a provider or owner of the business, potentially add penalties, including false claims penalties, and may seek to withhold future Medicaid payments until that overpayment has been satisfied. We're also responsible for excluding, suspending, or disqualifying providers. And a debarred, suspended, or excluded provider is either a person or an organization that has been excluded from participating in federal or state-funded healthcare programs. So that's Medicare, Medicaid, that sort of thing. And any products or services that a debarred provider directly or indirectly furnishes, orders, or prescribes are not eligible for payment under those programs. So it's really important that providers perform exclusion checks when they hire somebody, as well as monthly thereafter. And this referenced newsletter provides more details. I'm not going to go through this entire list, but this just gives an overview of the various websites and lists that should be consulted when you're trying to determine if a provider has been excluded. And I want to point specifically to the last item, number 7. So if you are working with somebody who's out of state, you must also check that state's exclusion and debarment list. So it's not enough just to check what we've got here internally in New Jersey or some of those federal databases, but we also require that you check that state's exclusion or debarment list. And these are all linked for you, and they will be accessible when you receive the slide deck. We also want to talk about self-disclosures. So there might be times when you realize you made a mistake or you found mistakes within your organization. So anytime you identify those, you must reveal those issues to MFD and return the inappropriate payments. There is a link to the website that provides more detail on that. And according to the Affordable Care Act, this does require that any overpayments from Medicaid or Medicare be returned within 60 days of identifying them. Providers who follow those protocols for proper self-disclosure can avoid imposition of penalties. So there's a form on our website that provides the information that we would need. You would just follow the steps and submit it, and we would take it from there. So I want to make sure that everyone is very familiar with that and comfortable with the self-disclosure process. And I'm going to turn it over to my colleague, Mary Kay. She's going to touch briefly on third-party liability.
Good afternoon, everyone. Just briefly, I want to touch on this. As some of you all know, there are a lot of codes within this program that third-party carriers may not cover. This is basically just a reminder to please check the recipient's third-party insurance. If it's different, you see our phone numbers here. If it's different than what we have in our system, or it's not active anymore, to let us know. And just to be very mindful that from year to year, insurance coverage does change from insurer to insurer. A lot of focus is on mental health and developmental health. So I encourage you to make sure that none of the services you're providing has not switched to now being a covered service under that insurance. And just be aware that it's, again, to let us know on these two phone numbers if you've come across coverage that the person no longer has in the Medicaid system on the emails that you can access showing the insurance. If it's changed, to just let us know, and just, always remembering that Medicaid is the payer of last resort. But, just double check. I understand some of these codes are not covered by third party, but, coverage is changing all the time, and just be very, very cognizant of this. And that's really all I have. If you have any questions, you can get me at one of those numbers below.
Thanks, Mary Kay. We'll turn it over to Detective Rosati from the Medicaid Fraud Control Unit.
Good afternoon, everybody. Detective Mike Rosati with the Medicaid Fraud Control Unit. If you could advance the slide for me. Medicaid fraud is a serious crime. It can have profound financial impacts on the program, and it also poses a threat to public health and to public safety. The Medicaid Fraud Control Unit within the Office of the Insurance Fraud Prosecutor is the criminal oversight entity for our Medicaid program. As previously shown way back on slide 10, OIFP falls within the Department of Law and Public Safety, along with the New Jersey Division of Criminal Justice. Our office, the Medicaid Fraud Control Unit, investigates and prosecutes Medicaid fraud. We have the additional responsibility to investigate related criminal offenses. So that would include crimes with a connection to Medicaid funds or Medicaid funded facilities, and or criminal activity that relates or negatively impacts Medicaid beneficiaries. The Medicaid Fraud Control Unit consists of our prosecutors, who are deputy attorney generals, and they prosecute cases for the office. Also criminal investigators, who are sworn law enforcement officers. That includes detectives, sergeants, lieutenants, and deputy chiefs, who investigate crimes and supervise those investigations. Also civil investigators, who assist in criminal investigations, also investigate civil cases, civil asset forfeiture actions, as well as violations of the Federal False Claims Act. And our office also utilizes additional resources. Those are nurses, auditors, and other support staff, with our shared responsibility being policing the Medicaid system. Next slide. The Medicaid Fraud Control Unit investigates and prosecutes alleged criminal actions. This includes allegations of physical abuse to beneficiaries, healthcare providers who are suspected of defrauding the Medicaid program, fraudulent activities by providers against the Medicaid program, fraud within the administration of the program, and fraud against other federally or state-funded healthcare programs where there is a Medicaid nexus or connection to Medicaid. Next slide. So just one of the applicable criminal statutes that I'll highlight here would be criminal healthcare claims fraud, NJSA 2C 21-4.3. In summary, it is illegal to submit a false claim to the Medicaid program or to any insurance company in order to be paid for healthcare services which were not actually provided or rendered. These offenses are punishable by up to 10 years in state prison. In addition to all other criminal penalties allowed by law, a violator may also be subject to a fine of up to 5 times the amount of any false claim that is submitted and sought for reimbursement. Suspension or debarment from government-funded healthcare programs would be an additional consequence, as well as forfeiture of professional license. So these are potential consequences just for healthcare claims fraud, which could include billing for services not actually rendered, misrepresenting the service type that was actually provided, or misrepresenting that certain required components of the service were actually provided when in fact they were not. So on its own, this offense has strict penalties, but there are also typically other co-occurring crimes or secondary crimes that we usually see in cases. So that could include additional crimes of theft, abuse and neglect, corporate misconduct, Medicaid fraud, tax evasion, and then other crimes relating to controlled dangerous substances. Next slide, please. So in case you did not know, if you are a practitioner and you hold a professional license, you only need to submit one false claim to be convicted. Willful ignorance of the truth or falsity of a claim is not a defense. You can be found guilty of healthcare claims fraud, even if your claims were not intentionally fraudulent. If you submit a false claim or cause a false claim to be submitted in a reckless manner, this is still a crime, even without specific knowledge or intent. Okay, next slide. So the bottom line, to keep things simple, is ignorance of the law excuses no one, and it is the provider's responsibility to know the laws that apply to their area of practice. Thank you.
Thank you, Detective Rosati. So we're going to start with getting today's presentation wrapped up, and we've got a number of helpful slides that I will go through. And again, the slides, as well as a link to the recording of this presentation, will be posted online, and links will be shared with all of you by email within the next few days. So if you have questions after this, here are contact information for the agencies that were involved in today's presentation. So please do not hesitate to reach out. And then additionally, we're aware that this service line is currently through fee-for-service and is not managed care, but just as a reference point, we've included the fraud hotlines for the New Jersey Medicaid managed care organizations. And before we let you go, we really do want to know what you thought of our presentation today. So I'm going to launch a very quick 3-question poll. And if you could just take a moment to let us know what you thought, we would really appreciate it. Just another few seconds. All right, thank you for that. Now, I have noticed that we've had a lot of questions rolling into our Q&A. The way that this will work is for those of you who have submitted questions, the Q&A will document who you are and how we can get in touch with you. I believe some of those questions have been answered in real time. If anybody entered a question into the chat, which I think some of you have, we just ask that you please try to enter that in the Q&A. The chat doesn't preserve the information, and so we want to make sure that we really can get in touch with you and answer any outstanding questions. Before we wrap up, Tracy, are there any questions that you want to touch on while we have a few minutes? Or are the remaining questions ones that we need to do a little bit more research and get back to individuals about?
Melanie, there actually was one that I saw three or four people asked, and it was in regards to immunizations. They wanted to know, after the public health emergency, is that still going to be a requirement?
Steve, are you still on, and are you able to speak to that, or is that something we need to take back and respond to following the presentation? I see Steve still on, but he is muted. So for those of you that asked that question, we acknowledge that we've received it, and we will share all the questions and the corresponding responses, so long as it's not a confidential matter. We will share those across all of the attendees today so that you get clarification, because someone's question is presumably another person's question. Anything else, Tracy, or?
No, I think the others we've either responded or we need to research them first. But
Okay.
just to reiterate what Melanie said, we're going to research them and then post the answers back. So if we didn't get back to you today, we will.
That's right. And I also want to point out that within this appendix, we have the regulation for IIC service delivery and each of the subpoints and what that covers. So this is, I think, a really helpful reference tool for all of you. And there are 3 slides dedicated to that. And then last but not least, please follow the Office of the State Comptroller. We do a lot of great work, and we really would love to hear from you if you have any ideas or any feedback for us. And last but not least, at the very bottom is the provider education email address for how to get in touch directly with me, Melanie Donnelly here at MFD, if you need to do so. All right, I think with that, we are ready to wrap up. I want to thank all of our presenters today for the time and effort they put into preparing this presentation. And I want to thank all of our attendees for staying with us. I know 90 minutes is a long time out of your busy days, but hopefully you'll have left here with some really great information. Slides and questions and responses will be forthcoming, and we hope you enjoy the rest of your afternoon. Thank you so much, everyone.
Melanie.
Hey,
Hey.
we still have some folks who are still signing off.
Okay.